hand over to you. From there, you can proceed.
Sure.
All right. So, with all your due permission, we are beginning with the session for today. Very
Mm-hmm.
good evening to one and all. This is Batul from IJCP, the moderator for today's session, and I would like to welcome everyone wholeheartedly at our platform for the better exchange of knowledge that is going to be shared by our renowned stalwart who is present here with us today. Well, sir needs no introduction, but yet it's our great pleasure and honor to introduce him. He is none other than the very renowned urologist, Dr. Anil Madhani, sir. Sir is MBBS, MS Surgery, MCH Urology, DNB in Urology, Executive Director at Urology Fortis Healthcare, Gurgaon. With such wonderful insights, we are going to talk about the topic for today, which is prostate cancer screening, the role of PSA testing. Before moving on to today's session, let us have a brief look on what the topic says. So, prostate cancer is one of the most common cancers among men, but early detection can make a significant difference in these outcomes. So, we'll be learning about the informative session on the PSA test designed to help individuals understand when and why this screening might be beneficial, as well as potential risks and limitations. So now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him for his precious talk to begin. So over to you. Please proceed.
Thank you very much for your kind words. And good evening to everyone. And you must excuse me for interrupted bad voice because of unfortunate weather in NCR. So, today's topic I chose because many of my friends, like I have crossed 55 years of age, and many of my friends and family members ask me, have you got your PSA done? Uh, because when you talk about screening, unfortunately, in most of the cancers, screening controversy still exists, and same as with prostate cancer. So, when I was young, I mean, in previous old days, we used to say that medicine is art and science. Then science prevailed over with development of technology and modern science. So we used to think that science is taking over the art of medicine. But as you grow old, you gain wisdom, you realize no, it is not so, because the art of medicine is still very important than the science, because the science means your publications. There are level of evidences, one, two, three, four. Level one is supposed to be the best evidence, but you see, with the same papers, if you read about any guidelines in medicine, like for control of diabetes or for heart surgery versus stenting, or you just look at the screening of breast cancer, there are four or five societies, and none of those four or five societies would give you one single answer. So that defies all the evidence in favor of facts. So medicine is not a fact; it is more often than not is a myth. So, if you ask me, what is the death rate from cancer? Like, how many people are dying of cancer? So, if you get six deaths as a given point of time, one out of six deaths is due to cancer. So, this is a significant problem. And if you look at the data, the gross data, like how many patients are adding up every year? So it says around 15 lakh, 1.5 million new patients every year. And if you look at the new incidence or new patients getting recruited in the pool from India is around 7 lakh. So this is the number. This is the most common cancer in male and female. This is world data. So if you look at for male people and male sex, then prostate cancer, which I am going to talk about, is the second most common cancer in the world. But if you really look at the Indian scenario, so this is data from ICMR, prostate cancer is not among top five cancer. I think it comes at around eighth or ninth position. So it's not that common as you find in the world. There are various reasons to that, and I'm not going to discuss about that. But if you look at the incidence, unfortunately, we do not have exact data from India, but you can extrapolate data from Asia. Now, just to make you understand, the incidence rate in Northern Europe is the highest. This is around 82 patients per 1 lakh population. So 1 lakh population of male, 82 will have prostate cancer. Uh, and then the red one is death rate. So out of those 82, only 12 are dying. But if you look at the statistics from India, I mean, this is extrapolated statistics, the South Central Asia. So the incidence is much, much lower, 6.4, but the death rate is quite high. So incidence is low, but the fatality rate is quite high with prostate cancer. So this is probably due to the late detection of prostate cancer in India, as we do not have screening program like you have for the breast cancer and probably for cervical cancer. So, as I said, we do not have a national policy on prostate cancer screening. So, what is the correct picture we should understand to practice medicine and to advise PSA screening? So, as you know, PSA screening, the whole purpose of screening is to pick up cancer at the earliest stage. Now, the question comes, if you detect cancer at early stage, will it change the survival? The question is screening helpful in reducing mortality? So that is the moot question. It is very controversial question. As I said, the science regarding screening is not a fact. There are a lot of misinterpretation, but we need to be use our wisdom to practice medicine in current era. So just to give you a brief about PSA. PSA is a protein which is secreted in the semen. So this is proteolytic. So main function of PSA is that it lyses the coagulum in the semen to make sperms more motile. Now, this is contrary to the common knowledge that in prostate cancer, PSA is increased because we do, whenever we run a test and we have defined the normal range of 0 to 4, excuse me. So if it is more than 4, then you trigger a button to run more tests to diagnose prostate cancer. So, contrary to the common knowledge, in cancer prostate, PSA production is less. So, this is leakage through the epithelium, leakage of PSA through the epithelium into the blood that results in higher value of PSA. So this is just to give you a glimpse about my statement when I said the medicine is no longer pure science because the same science can be interpreted by different societies in different way. So this is about the mammogram for breast cancer. If you look at the three major societies, all three societies have different recommendation. And similarly, for prostate cancer, if you look at the age range, it varies from a different society. But what we follow commonly is we should screen male patients or male people from the age of 50 to 70. Because after 70, there is no point detecting the prostate cancer. Now, you might think that why not? If a person is 70-year-old and is likely to survive for more than 20 years, why not get his PSA? So that is absolutely true. So grossly, what we follow, the way we screen our male population, not the population, unfortunately, as I said, there is no policy of screening in India. But if you are a male more than 50 and you have life expectancy of more than 10 years, then of course you should have your PSA tested. So the broadly the screening is of two types. One is organized screening, which when you screen healthy asymptomatic men. So this is not at national level, but most of the corporate hospitals in major cities are testing is part of the routine health check, which is getting very common. So this becomes close to national recommendation for screening. And the second is opportunistic screening. I mean, if any male presents with voiding symptoms and he presents to urologist or any physician, he gets his PSA done. So that is opportunistic screening. So this is the broad. This is a slide denoting two major studies which answered the question, and the question was whether screening reduces the mortality or not. Now look at the figure. So these two broad randomized trial from America and European countries, they concluded that it does help in reducing mortality. But if you look at the numbers, like if you really want to prevent one death, you need to screen 1,400 men and you need to treat 48 men. So 47 would have unnecessary treatment to gain that figure of saving one death. Now, interestingly, when these two large studies were published, so there is a society in the United States, as a U.S. Preventive Service Task Force. They reanalyze the data, and you will be surprised at the recommendation, because most of the primary physicians in the United States, they follow the guidelines given by US PSTF. So what they recommended is that regardless of the age, men without symptom should not routinely have their PSA tested to screen for prostate cancer. So they gave a recommendation D. Recommendation D from this society means screening is useless. Now imagine the whole world with the development of robotic prostatectomy and the kind of radiotherapy we have. So the whole world got disturbed with this kind of recommendation. There was a lot of hue and cry, most of the urologists, because if you stop screening and detecting prostate cancer, they would be out of their jobs, because in the US, the way they are removing prostate is just like way we are removing gallbladders and uterus in India. So that's the reason most of the urologists protested against it. So this society had to change the recommendation from D to C, and smartly said that you need to discuss with the patient before you prescribe for PSA screening. Mind you, this is not opportunistic screening. This is a screening of a healthy man who is beyond 50. So that was about the broad perspective I have given to you regarding screening. Now, before you advise anyone for PSA, you should keep few things in mind. That patient should not have urethral pain frequency, which are the signs of infection, lower tract urinary tract infection. Patient should not be in retention. Suppose somebody comes to your clinic with retention, you catheterize him, you should not send his blood for PSA, because PSA could be spuriously raised, and that would unnecessarily ring the wrong bell. And patient is on 5-alpha reductase inhibitor, that is dutasteride or finasteride. A patient have recent cystoscopy, then you should be careful about sending PSA. So this is one study from my previous institute. This is my own paper. So what we studied that, because this is a perception in India, most of the men after the age of 60-65 are not that sexually active. So they have subtle inflammation in the prostate that gives rise to higher PSA. So the PSA, raised PSA is not actually due to cancer, but this could be because of the infection. So we did prove that if we treat such patients who are not sexually active or have some kind of symptoms related to prostatitis, we gave them 2 weeks of antibiotic and repeated PSA after 6 weeks. It magically brought down the PSA to normal level in almost 65% of men. So, what is the scenario in India? Now, do we have data? I think this is a very important paper from me only. I mean, what I did, I was in SGPGI for almost 20 years. So, I collected the data from SGPGI where you just screen men who are coming to your OPD and who are symptomatic. And I worked in Vedanta for almost 4 years, and I collected the data from that institute because they have executive health checkup. So I compared these two data set. And interestingly, if you this is a busy slide, but I'll just give you one important information. So this first table is from SGPGI and second is from Medanta. So symptomatic men, we presume that if person is coming to your OPD with lower tract symptoms, his PSA would be high. So the PSA positivity rate, when you draw blood, suppose you test 100 men for PSA, out of 100, how many would have PSA of more than 4 nanogram? So that is PSA positivity rate. So PSA positivity rate was quite high in symptomatic men than asymptomatic men. So this is another interesting data I think you must know, that the advantage of uh, screening asymptomatic men or healthy men is that none of these patients is almost 9,000 odd patients, and this is around 19,000. So when you look at the metastatic prostate cancer, so none of the patients or none of the men who had not patients, none of the men who had executive health check presented in advanced prostate cancer. So this is a robust data to say that we should screen our men too. So, what is the next step we take when the PSA is high? Now, many of you might think that the next step would be biopsy, but these days, the way we are approaching such men with high PSA is absolutely different. The next step most of the urologists are getting is multi-parametric MRI of the prostate. So, like when you have MRI of the breast, you have BI-RAD scoring. Similarly, we have PI-RAD scoring for prostate cancer. So, the score stands from 1 to 5. 5 means higher probability of that lesion being cancerous. After that, if patient is ready for biopsy, we do trans rectal biopsy, or there is another approach which is making us quite interested, and I also follow that. Then I get PSMA PET CT. So the PSMA PET CT will give you standard uptake unit, and if it is correlating with the same lesion and giving you the same indication that this lesion could be malignant, then probably we can avoid biopsy. But that is still in experimental stage. So I would not recommend, or I would not tell you to skip biopsy. So the biopsy, the way we do is transrectal biopsy, but look at the yield rate. Like with higher PSA, like 4 to 10 PSA range, if I do 100 biopsies, out of those 100, the detection rate is around 11 to 25%. So 75 would have unnecessary biopsy. It comes with added risk of sepsis, discomfort. It can cause retention, hematuria. So biopsy, maybe in coming 5 years, if I happen to talk about this, I may not tell you that this is any longer indicated. So let's see. So there is another kind of biopsy, which is MR fusion biopsy. When we fuse the image of MR with ultrasound to increase the yield rate of biopsy. This is another way we are doing transperineal biopsy, which is which we go through the perineum and avoid the rectum as a route to reduce the sepsis rate. So I think that's all I had to share with you. So in nutshell, the take-home message is for this talk is what should we do? I mean, as a clinician, what should you do? So PSA should be done after the age of 50, and when you think that a person is having life expectancy of more than 10 years, and of course he should have PSA. So raised PSA does not mean he has cancer. So you see there are a lot of psychological issues because thanks to Google and AI, most of our patients have become citizen scientists, and they get a lot of information from Google. So they get perturbed when they see their PSA at higher values. Then exclude all the factors before you write PSA to your patient. As I said, if patient has dysuria, burning while passing urine, or he had a recent cystoscopy, you suspect any kind of infection, you should avoid getting PSA done. And trial of antibiotic, if you suspect such situation, just don't jump to MR or PSMA or biopsy. Just give him a trial of 2 weeks of antibiotic, and probably you would bring his PSA down to normal. And in future, MPMRI and PSMA PET would be a useful adjunct to avoid biopsy. And of course, no biopsy diagnosis of prostate cancer would be the way we will deal with such patients. Because in urological cancers, if you look at the renal cell cancer, or if you look at the testicular cancer, we do not do biopsy. We just go ahead and treat them. So, ladies and gentlemen, that's all I had to share with you, and I would really be happy to answer a question from your side. Thank you very much.
Thank you so much, sir. Thank you for your overwhelming talk that you have shared on our platform with all your experience, and of course, the PPT slide that you have shared to make our viewers understand about this topic in such a better manner. Thank you so much for that. Moving ahead with the question and answers round, sir, we have received a few questions from the participants. So, with all your due permission, I would like to put across those questions to you. So, the
Please.
first question is related to the risk of overdiagnosis. So, what are the risks of overdiagnosis and overtreatment associated with PSA screening?
Yeah, so that's a very good question. You see, as I said, high PSA doesn't mean a patient has cancer, a man has cancer. So you need to be careful. You will do MRI and probably the PSMA PET. So that would give you whether patient has a significant cancer or not. I mean, prostate cancer, there is a grading system, Gleason grade from 6, 7, 8, 9, 10. So if MPMRI tells you this is a pyrite 4 and 5 or PSMA is positive, that patient definitely has high risk prostate cancer, and you can proceed for biopsy. Otherwise, you can just watch the patient. So it's your discretion. Here comes the role of wisdom that you need to make patient understand that though your PSA is high, you shouldn't get worried because it doesn't mean you have cancer. So just get these two tests done and just follow the patient up.
Thank you so much, sir. Thank you for answering that question. Moving ahead with the other question that we have received, and the question is related to the interpretation of borderline or fluctuating PSA levels. So, how should physicians interpret borderline or fluctuating PSA levels? Your take on
So
this, sir.
that could be because of inflammation in the prostate. So you see, even if you just don't get any other test and you wait for another 3 months, it's not going to harm the patient. So you have to consult the patient. And you see, interestingly, there is another paper from me, and I have suggested that your cutoff level should be more than 4. It should be 5.4. So it doesn't really matter if PSA is fluctuating. If it is because of cancer, it should not come down. A PSA, once PSA you get, it is 6 nanogram, maybe repeat it and it comes down to 4 or 3.5, then it's unlikely to be malignant. So fluctuating PSA, you shouldn't worry. The waiting for 3 months or 6 months would not cause patient any harm.
Thank you so much, sir. Thank you for answering that question. Moving ahead with the other question, and the question is related to the follow up protocols. So, what is the recommended follow up protocol for elevated PSA levels?
Yeah, again, see, elevated means how elevated it is, and patient has family history. PSA is more than 5.4 or for 6 or 5 6 range. Patient doesn't have any other reasons for raised PSA. Then obviously you would get MRI and PSA method, and probably good get biopsy. If biopsy is negative, don't worry about the cancer for another 1 year, and after 1 year we can repeat the same steps. So this is when PSA is high. I mean, if you have cancer, obviously you will go ahead and treat it. And high PSA with MRI, Pirate 3 or 2 or even 4, and biopsy is negative, then just don't do anything for 1 year. And if it is positive, then obviously you have to treat the patient.
Thank you so much, sir. Thank you for answering that question. Before we conclude, sir, last question, and the question is related to the ethnicity. So, what role does ethnicity play in the risk of stratification and screening approach for prostate cancer?
Yeah, so ethnic, as I said, the incidence in India and Asia is quite low. It's much lower than the incidence in North America and Europe. So the probably what we presume, you see, in epidemiology, it is very difficult to prove cause and effect. So they blame it to red meat, excess intake of red meat, obesity, and probably genes. Some because the cancer is familial or genetic. So the incidence of familial and genetic cancer is quite high in the US. So these are the probable causes, but it's very difficult to prove why Indians have a low incidence. But one interesting fact, like I discussed with one of my colleagues in the US, they say that Indians who have moved from India to US, they stand the same chance.
Thank you so much, sir. Thank you for answering that question, and of course, all the other questions for our viewers, and for making them understand about the topic with all your experience that you have shared on our platform, and with your all your insights that you have shared on our platform, for making their clinical practice a bit more easy and a bit more informative. So, thank you so much for that, sir. And I
Thank
would
you
like to
very much.
thank all
Thank
our
you.
viewers as well for their ardent participation that they have shown by staying tuned with us throughout the session and putting across such interesting questions to us. So before we conclude, sir, any last take-home message from your end?
Yeah, I think you see, I mean, I always because I used to teach a lot in urology. I always tell my residents and my colleagues that you should never follow any guideline blindly in medicine. Unfortunately, commercial angle has peeped in to the facts, and we twist most of the facts. So never ever accept any guideline blindly. Always keep challenging guidelines and use your wisdom. That's all I would like to say. Thank you, and have a pollution-free weekend. Bye
Thank you
bye.
so much, sir. Thank you. Thank you. Bye,
Okay,
sir.
dear. Bye.